Okay, I think we're live. Hi, everyone. Happy Wednesday. I almost said happy last day of the month, but we do have this extra day tomorrow for February. Happy Wednesday. I almost said happy last day of the month. Feedback. We do have this extra day tomorrow for February. Happy. Okay, I think that's better. Can you hear me?
Yeah.
Right, good. I was getting feedback from another page being open. So welcome to the Healthy Menopause Project. Welcome, Michelle. I'm so glad that you have agreed to have me interview you. If you're new to our menopause page, I really started this page this summer because I wanted to, first of all, learn more about my own menopause journey. I'm Amanda, I'm 49, live in Denver, have two teen boys, and was like, what the heck is going on right now with my body? And so I was curious about to learn more about my own self. And I thought, well, there's probably lots of other women out there that are also curious. So I've been diving into the world of menopause pretty deeply and have linked arms with a lot of cool practitioners out there. And Michelle is one of them. We met a couple months ago. She's a physical therapist, and that's my background as well. And so I just wanted to pick her brain on physical therapy and pelvic floor and women's health. And she was so gracious. Michelle's in Denver. She'll talk about her clinic in a minute, but we collected some questions from you guys, but please put more in the comments. We can't see them right now because we're on Zoom, but we'll come back to them. And if you have any, thing else that pops up, certainly put it in the comments and we'll get to it. So let's dive in, Michelle. Tell me, I guess we'll just start with from the beginning. Tell me about you and how you ended up here talking to us about pelvic health.
Yeah, that's great. And thank you so much for the opportunity. And thank you to all of you that submitted questions. This is really great. It's a topic I love to talk about. So I'm Dr. Michelle Logging. I'm a physical therapist and I'm a pelvic health specialist. I became a physical therapist in 2008 and I started working in an inpatient setting. And so my specialty is a little bit unique. I actually have a specialty working with clients with eating disorders. So I have a special certificate, a designation, certified eating disorder specialist. And that's kind of what brought me into the pelvic health space. Honestly, it's twofold. In terms of I was interested in pelvic health because when I was looking at medical charts for my clients in the hospital, oftentimes I would read this diagnosis, pelvic floor dysfunction. I'm like, wow, that's an umbrella. There's so many things. And was curious as to whether there was something that I could have offered my clients or my patients. I kind of use that word interchangeably, clients, patients, at that time. So that was one way that I became interested in public health. And then the other route was my own journey in terms of I'm 50, I am in menopause. I have two kiddos, a 16-year-old and an 11-year-old. And it was just really kind of interesting, my journey having kids. So my daughter was actually born when I was in physical therapy school. And I had to go back to my classes a week and a half after she was born. So that was challenging. And then I did have a break, but I did need to go back to coursework. And then my son, I was working at Denver Health at the time, and I worked right up to my due date. And then I was back at work 6 weeks after he was born. So, and it was just really interesting because I had my own questions related to how my body felt so different. And that was obviously in the postpartum phase. And I didn't really feel like I got great answers, to be honest. And so kind of led me down this path, my own curiosity for myself, but then seeing how I could benefit my patients as well. So here I am in the pelvic health space as well.
Love it. Love it. And so true. So often in life, right? Our own experience kind of guides us into our own interest. So you talk about pelvic health dysfunction. Maybe we should just start with what is pelvic health for women? Like, what is that even? I know you have a model, like a spinal model, but maybe just show us what you mean when you say pelvic health, pelvic floor, like what do those things mean? Those are kind of thrown around.
Absolutely. So when a lot of what I do initially, like in an initial session with a patient, is a lot of education, just kind of like the anatomy and physiology, the nuts and bolts of how the body works, because we honestly don't typically talk about this area. Let me kind of shoot my camera down so you can see. So this is a pelvic model, but the pelvis is right here, right? So it's this area here. We often don't really talk about that or connect with it. So I do a lot of education around this is the pelvis, okay? And then this is a female oriented body, obviously. And inside the pelvis, I know it's a little hard to see and they're a little jumbled around, but these are the internal organs. So this is our uterus. I'm going to take these out as I kind of talk. The rectum back behind there. I know it's a little challenging to see. And then the bladder, let me kind of show you this. The bladder actually peeps right up in front of the pubic bone. And any of you that are actually watching this live, or if you watch it later, you could actually touch where your pubic bone is. It's down this top part of your pelvis. But if we talk about pelvic bowl, look at that. That's a bowl, and that's a bowl of muscles. So now I'm going to tip it up this way. So these right here, these are the sits bones. So we sit on these bones, right? And then just a little quick orientation anatomically. This is the pubic symphysis up here. And then as we come down, this is the clitoris. This is the urethra. So this is where we pee from, right? This is the vaginal opening. This is the perineum or the perineal body. So it's a really thick muscular area in between the vaginal opening and the anus. So this is the anus here, but this is all muscle tissue. So I talk a lot about essentially the pelvis, but also the relationship of the pelvis to the hips and the low back, because as you can see on this, whoops, I'm throwing organs around. As you can see from this model, it's a daily thing. As you can see from this model, this is our low back. So this is L5, L4. And then if you imagine that this is actually where our femur, the long bone in our leg, attaches into our hip. So you can see how this is a system. They all interplay together. So understanding that anatomy, and then if you think about what pelvic floor dysfunction is, I know I mentioned it earlier, it's an umbrella term, but pelvic floor dysfunction is urgency having to go to the bathroom, either pee or poo, or both, right? Having any incontinence, so leaking pee or poo, any sort of pelvic pain or pelvic pressure, constipation, abdominal distension, bloating, cramping, pain with sexual intercourse. There's like a list, endometriosis, PCOS, interstitial cystitis. That's a hard word to say. There's so many different things that interplay with the pelvic floor and can cause pelvic health dysfunction. So hopefully I answered that question for you.
Let me know. Gosh, that was so great. Yeah, because I think it's so good. I'm so glad you brought out the model because that really gives us a visual of everything that's connected. And of course, we didn't even talk about the ligaments and the, all the other soft tissue around there that holds it together. But you can see how that's such an important part of our body. And then obviously the breathing, I know we'll go into that, but just breathing and diaphragm and core muscles that are attached, like it's such an important part. So when women, we're going to be talking most about women today in menopause. I know pregnancy, a lot of women come to you in post-pregnancy, but for women in their 40s, maybe they're finished having kids, what are they usually coming for? Is there like a top 3 things you're seeing with these women?
Yeah, it's such a good question. The interesting thing, I was thinking about this, the interesting thing is that I feel that a lot of women in their perimenopause into menopause actually don't seek out pelvic health therapy. So I'm really glad we're having this discussion because hopefully it'll bring awareness to this. Because I think a lot of times what we see is we see pelvic health in pregnancy and postpartum, and we don't necessarily see it as often on social media and, wherever you get your information. We don't often see it related to menopause. But what I find is that women in menopause will be experiencing vaginal dryness, may have pain with sexual intercourse. And here's the thing, often they've had pain with sexual intercourse for longer, for like, maybe it's been going on for years, right? And it's kind of one of those things where it's like accepted as normal, especially in our postpartum bodies. Oftentimes what I hear, and this is what my patients reflect to me, is that, oh, that's normal. I've had a baby. It's common, but it doesn't have to be normal. So if somebody is leaking urine. Let's say they enjoy doing a CrossFit class and they like doing double unders. They always wear black leggings because they're going to leak urine when they do double unders. Well, that doesn't have to happen, and it's not too late to correct that issue. So I think that's an important thing
Yeah.
for women to know.
Okay, great. So leaky bladder tends to bring, and like you said, maybe a lot of these women, even probably women listening, may not even know that this is a solution for them. So this is good. We're
Yeah.
kind of fleshing this out. So they have leaking urine. You mentioned constipation. Maybe that would be a reason women would come to see you at this point. Pain, pain with intercourse, just bladder pain. Um, Okay, so that gives you, as you're listening, these give you some ideas of why you might go see a pelvic health specialist. So when someone comes to see you, I mean, I've never been to a pelvic health specialist, but I know it can be a little like, there's a little like, oh, are they going to make me, what's the exam like? Like, is it scary? Is it like going to the OBGYN? I mean, we're used to this, right? But tell us about how you kind of do your exam and what's involved.
Absolutely. I love this question because I think this is really can be a barrier for women to access this type of care because we just don't know what we don't know. And that's scary. So when I am working with a patient and we're going the pelvic health route, I will talk about what a pelvic health exam can look like, not what it should look like, what it can look like. And throughout that discussion and throughout any subsequent sessions, I really focus on body autonomy and that the patient gets to say what we do or don't do in the session. And they can say it at any time. I honestly, when I am planning out sessions, I have so many things that we can pivot to as needed, that we're not going to run out of things necessarily. But what a typical exam looks like is I will have somebody do some functional movement and kind of see how they're picking something up off the floor, how they squat, how they lunge. It really depends on, what they're coming to me for based and that functional assessment. Obviously, we talk about what their symptoms are, what seems to improve, what makes it worse, how long they've been going on, those sorts of things. And then there is the option to do an internal assessment. And this is the piece that can be quite comfortable for some women and really uncomfortable for others. And so this is where you can, I mean, really all of it, you can opt in or opt out. I can get a lot of information just from my questionnaire in terms of what route I feel that we need to go in terms of treatment. If we do an internal assessment does not involve the use of a speculum. So a speculum is the device that an OB-GYN would use during like a pap smear, right? An internal assessment is done with gloved hand, lubricated finger. And the way it works is that I would essentially bring my finger, again, this is with ongoing consent. So I maintain eye contact, I maintain dialogue with my clients throughout. And if they tell me that we need to go a different route, then we definitely go a different route. But if I sense that we need to go a different route, then I will communicate that with them and I will head a different direction. But an internal assessment is essentially where I can, and I'll use the model again. I lost a piece of it. So I'll use the model again, but what I can do, it's got magnets on it so I can show different layers of muscle tissue. But what I do is essentially my finger will come to the vaginal opening. And again, I check in with my client. And then from here, I can begin to insert my finger to the first digit. And then again, checking in with my client, I might move my finger around if I feel I can. If the muscle tissue is tense, tight, or if my patient is telling me that it's painful, then we'll kind of decide what's best, but I may stay right there. I'm not going to push any further because it's already painful and I'm beginning to ramp the nervous system up. And so I want to keep the nervous system calm, okay? But when I can begin to access with my finger, and I'm going to take a layer of muscle tissue off. So there's 3 layers of muscle tissue in the pelvic floor. I'm taking the first 2 layers off. I don't do that on my patients. I can't do that. But what I want to show you is if I am able to insert a finger, and if I can show you this way, I can get all the way to the tailbone and look at all this muscle tissue that I can manually release tightness in this muscle tissue. And that's oftentimes what I find. And that can be the cause of pain with sexual intercourse, pelvic pain. Constipation is a little bit different. Urinary leakage can be because our muscles are tight. And that's not necessarily because they're weak. Typically, it's both.
Yeah. Yeah.
Typically, it's both. But we need to loosen we need to provide length to the tight muscles so that we can build strength in an optimized length of that muscle tissue. Hopefully that makes sense.
Yeah, I love that. And, I think just so important to combine the education piece with the consent piece and just, doing every step of the way, but, to be able to really, for you to really sense what the muscles are doing, I'm sure is just so important. And then from there, I'm sure teaching your clients, like, this is how you could do it on your own, or this is what the next steps are.
Right.
Great. So I think that puts us at ease.
Hopefully.
And then what are some, this is so broad, but like, what do you usually send? What would be like a treatment plan as far as, like, let's say painful intercourse? Is that something that is there exercises they can do at home? Is there stretching? Like, is there some things that you're sending them home with and then they come back and see you?
Yeah, that's such a good question. So one of the things that I typically explain to my patients is that typically when we begin this work, it's not a one and done. So we typically need multiple sessions to calm the nervous system down, because there's definitely this interplay with the nervous system. And
sorry to interrupt, but we've talked about this could have been going on for 10 years, right? So it's like,
absolutely.
Yeah. Okay.
Yeah. So calming the nervous system down, and that can really allow us access to that lengthening piece. So honestly, it really depends on what the client's specific needs are. But most often I begin with breath work, which I know we've kind of talked about before. And that is really that opportunity to allow, again, it's a great combo. It can help to calm the nervous system. But if we can work on the motor control piece of it, because oftentimes we think, well, yeah, I breathe all day long, I know how to do that. Well, yes, you do. You know how to oxygenate throughout your body, yes. But how can we breathe a diaphragmatic breath that actually allows for that diaphragm to come down and allows for our pelvic floor area, these muscles, to relax? Because on our inhale, that is where our pelvic floor muscles should relax. And oftentimes what I find is that we don't typically have that connection, that mind-body connection with what's actually happening in the pelvic floor muscles. So that's where we begin. Like, can we feel a softening and a relaxation in the pelvic floor muscles? It's different than like relaxing your bicep or your quadricep. It's a different sensation, but once you feel it, you've got it. And so we can expand upon that. So that's number one, is the breathwork piece. And then oftentimes what I will provide are stretches. I don't begin strength work. So oftentimes there's this correlation. Pelvic health equals Kegels.
Yeah.
No, not always.
Yeah.
That's not the first line. And I don't typically call them Kegels. I call them pelvic floor contractions. But typically what we need to do is we need to find a way to offer length to those tissues surrounding the pelvis. And we can do some interventions within the pelvis, within the muscles in the pelvic bowl as well. I can teach clients that. We can use some different tools and things like that. But I often focus a little bit more externally because that's a little bit easier to access at home. So that's the other thing, is that I want to fit a home program into somebody's life that is already quite hectic.
Sure.
So I tend to give maybe 3 things, 2 to 4 things that they practice. And then we kind of touch base and see how that's going. Is it feasible? No. Okay, let's figure out how we can make it feasible, or, we'll figure out a plan. So we'll do stretches, and then we'll add in, as we go along, we'll add in the strengthening piece, because typically there is that component where there's tightness, and then we need to add strength in. But the strength comes after we find length within that muscle tissue.
Okay, that makes a lot of sense. And I just think it must just be really, women just must feel really great just coming to see you and knowing that they can have help, right? And just knowing, okay, there's a plan, and maybe it is me doing a little bit more at home or having some home exercises, but just knowing, okay, I can feel better and have less pain and not leak as much. That just must be really a great feeling for them. Let me look over my questions. So is
Sure.
there anything that we can do? Let's say we're not having pain, we're not having, we feel like our pelvic floor is okay right now. Is there anything that we can do to either not do or do to help our pelvic health over the next 5, 10, 15, 20 years so we don't
Yeah.
end up in adult diapers or, have pain and dysfunction?
Yeah, absolutely. Honestly, I would go to the breathwork piece. Really learning how to breathe effectively so that muscle tissue can relax. I mean, there can be dysfunction, I guess, decreased motor coordination within the tissue, and it cannot cause pain. So
Mhm.
typically, what I see is I do see patients that are in pain, right? Because their body's getting this system. But regardless of that, working on breath work, meditation, those are great skills in terms of, like, again, it's a little bit more global in terms of calming the nervous system down in this world that we live in, right? It's so hectic. It's always hustle and bustle, right? But I think one of the things is kind of bowel habits. And that's a really large piece that I educate on in terms of when you feel you need to urinate, do you actually go and urinate? Do you just in case pee? So if just in case pee means, oh, I'm gonna go pick up the kids from school, I better go to the bathroom first. So
Is
that's a
that
just
a
in
good
case
thing? Is
pee.
that a good thing or a bad thing?
It's not a great thing
Oh,
because what it's doing is it's training you to go when you don't actually have the signal from your
okay.
bladder telling you that you have to go. And
Okay.
so that's where we can start to get into this cycle of, oh, I'm going all the time, because you can't really differentiate between, do I actually need to go, or
Yeah.
I'm afraid that I'm going to leak or something like that. It makes perfect sense why people do it.
Right.
Um, but we want to kind of train the bladder to urinate every 2 to 4 hours.
Okay.
So we don't want to hold for long periods of time, but we don't want to pee every 15 minutes, right?
Right.
And then related to bowel habits. So in terms of bowel movements, when you get on the toilet, do you sit and strain to have your bowel movements? And if you do, then let's work on adding that breath work practice in. If we think about it, an inhale is where our pelvic floor should relaxing. Pooping should actually be very easy. Now, I know it's not always, but really working on allowing that relaxation. We don't want to strain. That causes hemorrhoids, that can increase chances of prolapse. And often prolapse is often what postpartum mamas are most concerned about. And so I do a lot of education about using a squatty potty. I don't know, I have one right here. So squatty potty is a fancy stool that goes around your toilet. And so it brings your legs up and it opens up that anorectal angle, and it allows for defecation to be easier. Should not be work.
Love that. And that's just a good, like, I talked to a lot of women already about gut health, the importance of fiber and making sure you're pooping every day just for the detox system, but certainly obviously for healthy pelvic floor and
Yeah.
all function too. It's just important to have, the daily bowel movements and making sure you're in a good position and all of
Mm-hmm.
that. So love that. So we'll be sure to bowel and bladder, breathing, and, I guess just be on the lookout for signs of leaking bladder, and
Mm-hmm.
get help as soon as you see the signs, right? Like don't
Mm-hmm.
delay.
Yeah. And I
Yeah.
think, honestly, like kind of speaking back to like my experience having my babies, like my body felt so different. And it's not standard of care to be referred to see a pelvic health specialist. So oftentimes you have to advocate for yourself. You have to kind of ask about that. And even then, in Colorado, we you don't need a referral to come see a physical therapist. So you can really go see kind of whoever you want. So that's a really, really cool thing about the state of Colorado. But it's just, I wouldn't necessarily depend on like your OB-GYN to refer you
Right.
to a pelvic health specialist, just not standard of care in this country. And it's kind of a shame.
Yeah, yeah, it is. It is.
Yeah.
Actually, that was going to be my next question is how do people access you? It sounds like they can just make an appointment without having a prescription.
Yeah.
And
Yeah.
just tell us a little bit about your clinic, how you do things, how people find you.
Yeah, absolutely. So, you can find me on the web. It's Strength Within PT. I think that's right. I
We'll,
should know
we'll
my
put the
website,
link in
right?
the comments.
Should
Sure.
know my website. I'm on Instagram too. So, Strength Within PT. So you can always like send me a DM or anything like that. But yeah, I mean, you can come into the clinic. You can, what we typically do is we'll do what's called a discovery call. And so what that is that's an opportunity for us to talk with whoever is interested in potentially coming into the clinic, and we talk about our process. We answer any questions, whatever they're curious about. So say it's somebody that's in their 40s and they're leaking urine, so we'll talk about the process with that. And it's just a way, it's a free call. It's a way to kind of get to know us and see if we're a good fit for you. We
Yeah.
may or may not be, right? So that's kind of a nice thing.
And
What
our
else would I say?
evaluations usually about an hour or
Yeah, that's a good question. Yeah. All sessions are an hour.
oh,
So I map out a session. When I work with clients, I am prepared before they come, as long as they fill out their intake paperwork, because that's helpful information. And then I kind of know the direction that we need to go. But then it's kind of, I feel like a scientist in a way. I work with my patients and then I validate or I don't validate my hypothesis.
yeah.
And then that might take me another direction. But then it helps me to map out the plan of care, so to speak. So how many sessions we would need and those sorts of things.
Okay. Well, great. Well, we'll put all of that in the note or in the comment section of Facebook. We'll put your Instagram, your link, and you are in Denver, which is great. So if you're in
Yes.
Denver, easy to
Mhm.
access Michelle. Is there anything, our last question was, is there anything that you wish women, I think we've covered a lot of this, but I don't know if there's any final thoughts on anything you wish women would know about pelvic floor health, or do you think it's misunderstood about it?
Yeah, I love that question. We kind of talked about it a little bit. I think it's just that if something doesn't feel right in your body, whether it's pelvic health related or not, honestly, but if something doesn't feel right in your body, then you have the right to advocate for yourself. And so drawing that specifically to pelvic health, if something doesn't feel right, if you've gone to see your doctor and you don't feel like you're getting the answers to the questions that you have, or maybe you feel like you're not being heard, I would definitely kind of go the route of a pelvic health specialist, because in terms of a pelvic health specialist, we know the muscles, ligaments, all this stuff in the pelvis, and it's different than an OB-GYN. And I'm not saying one is better or that sort of thing.
Mhm.
It's just our specialty is different. As
Right.
physical therapists, we're experts in movement dysfunction and muscles. That's what all of this is. So
Yeah.
this is definitely our wheelhouse. Um, so I guess that's what I would say. And it's
Yeah.
never too late to do pelvic health. It's never too late.
Love it. That's such an important reminder. So for our mothers and grandmothers out there, certainly we could have them access pelvic health therapists as well. And certainly that generation needs it even, so much. So
Yeah.
glad there are more of you out there advocating
Yeah.
for women and treating women. And I know you also treat men, so you're not just,
Mhm.
yeah, so
Mhm.
you treat men as well. And that's for another show. But
I know.
but anyway, thank you for listening. If you're listening to us, be sure to let us know where you're listening from and what you enjoyed, what you learned, and we'll put all the links that we said. And yeah, good luck, Michelle, with your practice. And if there's anything else you want to pop in the comments that you think of later, please do. Thanks for
Awesome.
all
Yeah,
right.
thank you so much. Really
Oh,
appreciate it.
you're welcome. All right, talk soon. Take care.
Okay.
Bye.
Bye.